Oh, we'll be noisy in the office. Sorry? We'll be noisy.
Oh, yeah. Oh, I'm just admitting people.
Well, do you want to sit with us or not?
Good evening, everybody. We might make a start. Thank you all so much for joining. I'm David Hunter. I'm your moderator for this evening. It's a great pleasure to have you here. I'd first like to start by acknowledging the traditional custodians of the Northern Sydney Local Health District region, the Darug and Gurungai peoples, and pay my respects to elders past, present, and emerging. We're privileged to be joined tonight for a heavyweight showdown where science meets sweat and evidence goes head to head with experience. And the ultimate question is exercise worth the effort for osteoarthritis? And in the blue corner, hailing from the University of Melbourne, we have Professor Kim Bennell, a global force in physiotherapy and rehabilitation research. And she's published more papers on exercise for osteoarthritis than most of us have steps on our fitness trackers. She's known for her tireless advocacy of movement, motivation, and muscles that matter. And she's here to prove that exercise is the miracle medicine we've been waiting for. And in the red corner, all the way from Copenhagen, the land of the Vikings, strong coffee and impeccable trial design, we welcome Professor Marius Henriksen, a world-leading clinical researcher who's spent decades examining whether exercise truly delivers on its promise, or whether we've been overprescribing the plank. He brings rigor, skepticism, and Scandinavian precision, and tonight he's ready to challenge the exercise orthodoxy. Together, they've published thousands of papers, changed international guidelines, and shaped how we think about osteoarthritis management. But tonight, they're not here as collaborators, but as combatants in the quest for truth. And here's how it's going to go down. We're going to start with a poll to better understand what you, the audience, actually thinks about this topic before they get started. Then 15 minutes each for opening arguments, Kim for exercise, Marius against. Then 10-minute rebuttals where things might get a little bit more combative. And then we'll finish with a little bit of question and answers. For the Q&A, please place your questions in the chat. Please don't ask to unmute yourself to ask the questions. You can only do that through the chat. And then after that, there'll be a final audience poll to decide who's swayed your evidence-based hearts. So without further ado, what we might do is get Kim and Marius to lace up their metaphorical gloves. You adjust your ergonomic chairs and get ready for a battle of ideas, data, and Danish wit versus Aussie grit. We're going to start with a poll. So Lon, if you don't mind, I might get you to poll the audience, and I'm going to show you my little witty version of what I think of Marius and Kim. So please go ahead and Okay, Marius, you're. I'm assuming everybody can see this, Lon, but let's just say there's a heavy predisposition towards people being in favor of exercise. Okay, so we might end the poll there. And Kim, I'm going to hand the microphone to you. Go forth, prosper. And if I stop sharing here, you've got it? Okay.
That's all right. Can you see that?
Yeah, I might just close the poll because otherwise you can see that. Is your screen free, Kim?
Yes.
Yep, go ahead.
Okay, thanks very much, David, for the invitation to speak. And I think Marius has got a long way to go having a look at that poll. But you should never underestimate your opponent. And I do know that the Danes are, they're known for being pretty tough. So I know that Marius has probably got a lot up, up his sleeve. So I'm on the lookout. So what I did was, with the question, is exercise worth the effort? I thought I would go to the source of all truth and knowledge to ask that question. So I went to ChatGPT and I said, is exercise worth the effort for osteoarthritis? And what it said was, yes, exercise is absolutely worth the effort for osteoarthritis. Absolutely, I underline that. And you can see it gives a whole range of reasons why. But at the bottom, you can see, fifth point, it's been proven by research with large studies consistently showing that exercise is one of the most effective treatments for osteoarthritis, just as important as medications and often safer. So that's great. But as researchers, we don't just go with one. We like to replicate our results and make sure that they're reproducible. So what I did then is I went to Copilot, another AI platform, and I asked the same question. And again, the results are replicated. Yes, exercise is absolutely worth the effort for managing osteoarthritis, and it's now considered the most effective and safest treatment, even ahead of medications and surgery. So I think I can stop now. No, but I won't, because obviously, we know that AI has some issues. So we also turn to, what do clinical guidelines say about exercise and osteoarthritis? And for those of you who aren't familiar with how clinical guidelines are formulated, you get together a group, an expert panel with a lot of really smart people and consumers with lived experience, and everyone comes together. And then you can see up here you have systematic reviews of the literature to look at all the evidence from the literature and to rank the evidence and to grade its quality and so forth. And then you come up with recommendations. So it's a very rigorous process. And there's a number of different clinical guidelines from around the world about how we should manage osteoarthritis. And all of the clinical guidelines, all of them are consistent in recommending education, exercise, physical activity, weight loss, and pain management strategies. So exercise and physical activity is a core recommended treatment by all of these clinical guidelines from around the world. And I just highlight here the guidelines for Australia, the ones from the Royal Australian College of General Practitioners. And this is their last iteration of guidelines. And this is what they've said about land-based exercise. This is for the knee. It says, we strongly recommend offering land-based exercise for all people with knee osteoarthritis, and it was the same for the hip as well, to improve pain and function regardless of their age, their structural disease severity, their functional status, or their pain levels. And you can see that that was a strong recommendation. In Australia, we also have clinical care standards, and these are the ones for osteoarthritis of the knee. And you can see they're endorsed by multitudes of organisations, high-level organisations, the Australian College of General Geriatric Medicine and Musculoskeletal Health Australia and Arthritis Australia and so forth. So lots of endorsement of these recommendations and these quality care standards. And the number 4 quality care standard is about physical activity and exercise. Again, saying the same thing. A patient with knee osteoarthritis is advised that being active can help manage knee pain and improve function and so forth. So again, we have this consistent recommendation across care standards, across clinical guidelines, strongly recommending and endorsing physical activity and exercise. But we asked that this is a question that was proposed. Is exercise worth the effort for osteoarthritis? Well, I don't think that I, as a researcher, can answer that question. The only person that can answer that question is the patient. And that's what we need to do. We ask the patient, is exercise worth the effort for osteoarthritis? And if we are truly practicing patient or person-centered care, that's what will happen, is that the person or the patient will weigh up the benefits of that treatment, the harms of the treatment, the costs of the treatment, what other options there are around treatments, and what their preferences and values are, and then they will decide whether exercise is worth the effort for their osteoarthritis. So let's go through some of these. What about the benefits of exercise? Well, there are a whole range of benefits that we know that exercise produces, and in particular for osteoarthritis, reducing pain and improving function. So all of these different impairments that we see that can be associated with osteoarthritis, exercise can be beneficial for all of these. And if we look at the evidence, this is from the most recent update of the Cochrane Review of Exercise, and this is exercise of the knee. It was led by Belinda Lawford in our team. And you can see that it included 139 clinical trials. That's an enormous number of clinical trials and over 12,000 participants across all of those trials. Some of the trials compared exercise to a placebo or an attention control. Some compared exercise with either usual care or no intervention or a limited education. And then other trials evaluated exercise when it was added to another intervention versus that intervention alone. And probably what's of most interest, I think, to patients is what is the evidence for the effects of exercise if we compare with if we don't do any exercise. And so here is the results. This is showing the standardized mean difference, so bigger numbers, even though they're negative, that's just the way it was calculated, but the bigger the numbers, the means, the bigger the effect of exercise compared to the comparator. You can see that when it's compared to no treatment or usual care, here around about sort of 0.7 and beneficial, and then when it's compared to placebo or attention control, still beneficial, but not quite as much as when you compare it with no treatment. And we would consider these effect sizes or the benefits to be what we would decide as or describe as moderate to large effect sizes. So from all of this research, that's what the evidence shows us. But we also need to listen to the patient, and so we can pull all the results together like we did in the last slide. But it's also good to have some qualitative research to listen and try and explore what the patient experiences have been. And this is just some snapshot of some quotes from a study that Kim Allison and our team did about exercise. And you can see, Bill, since I started on the program, things like aching in the early hours of the morning, I haven't had those aches and I don't even know my pain's there. Brad, he's hitting the ball much further when he's playing golf. And Mary has now been able to start back at the gym and go to Zumba and feel much more confident. So, you can have numbers, but listening to the experiences of people with osteoarthritis undertaking exercise is really beneficial as well. There's also research showing that increasing general physical activity levels or the intensity of exercise can be beneficial. So for example, here there's a study showing that greater than 6,000 steps per day is a threshold for protecting against developing functional limitations over 2 years in osteoarthritis. And then there was another study that showed that 45 minutes of moderate to vigorous physical activity a week predicted improved or sustained high physical function over 2 years in those with symptoms. There is also evidence to show that exercise may reduce the need for a joint replacement down the track. One particular study showed that it reduced the need by 44% for having to have a hip replacement 6 years later in that particular study. And at the knee, there was a 68% reduction in the need for a joint replacement 2 years later when these people were followed up after they'd done their exercise program. So it can also reduce the need for a joint replacement. comorbidities. We know that a lot of people with osteoarthritis have comorbidities. If you see here, 67% of people with osteoarthritis will have one or more other health conditions. And in fact, they're more likely to have at least 3 or more other health conditions when you compare with people that don't have osteoarthritis. And why is this relevant? Well, that's because exercise, when we treat the person, we don't just treat their knee or their hip, we're treating the whole person. And so exercise is going to be beneficial for all of the other health conditions that many people with osteoarthritis have. So this is an overview of systematic reviews looking at the evidence to support exercise across 45 different long-term conditions. And you can see here the bigger circles means that there's more systematic reviews for those conditions. And these are all the conditions where there's evidence of a positive effect of exercise. And you can see it's CO, chronic obstructive pulmonary disease, and there's cancer, and there's Parkinson's, there's asthma, there's stroke, there's dementia, there's prostate, there's MS. So a whole range of conditions can be benefited by exercise. So that's the benefit, but what about the harm? So when we're trying to weigh up, is it worth the effort? What are the side effects of doing exercise? Well, what the research shows us is that it's not harmful to cartilage and molecular biomarkers. It also shows that there's no greater progression on imaging or greater need for joint replacement. Sometimes people think that it's going to be detrimental or damage their knee. That's not the case. And there are mild adverse events in up to 25% of patients who exercise, but these are mild and they're generally temporary, such as an increase in pain that settles down. So they're only mild. So what we know is that exercise is safe for people with osteoarthritis. What about the costs? And obviously, with any treatment, we have to weigh up, the financial cost, how much time it's going to take us, and what a burden it is, and how much effort we're going to have to expend to do that particular treatment. But what we know about exercise prescription for osteoarthritis is that benefits can be gained from many different types of exercise. So if you don't like one type, you can do another type, and they'll all have similar benefits. We also know that you can get similar benefits from whether it's supervised or not supervised. Also, a range of different exercise dosages can be effective as well. So you don't have to bust your gut. You can just do an exercise dosage that suits. So, for example, in our work, we have developed and tested and shown that a number of free online exercise programs that we've developed are effective for improving pain and function. And these are all free. So it doesn't have to cost you anything to do any exercise. You can do it in the comfort of your own home and get the benefits. This is a study looking at the association between the prescribed dosage of exercise and the outcome. It was a systematic review using the systematic review data. And what you can see is that there actually wasn't a relationship. So you don't, just because you do more of the exercise doesn't mean to say that you'll get greater benefits. So in actual fact, you don't have to do a lot and you can still get the benefits. So from a time perspective and a burden perspective, that's great. Same from this particular study. This again was looking at the relationship between how many lower limb strengthening exercises you need to do and outcomes. You can see here, sorry, go back. Oh, sorry, I've got to go back. You can see here that you can get the same benefits just doing one strengthening exercise versus 8 or more. And it's going to take you 5 minutes to do one exercise versus 45 minutes to do 8 exercises. So you can still get benefits from just investing a little bit of time and effort. And then again, this particular study by Steve Messier, where he compared high intensity and low intensity strength training and again found similar benefits. So you don't need to bust your gut to get benefits from exercise. Okay, so now you go, well, okay, I could do some exercise, but what are my other options? What else could I do instead? Well, you could try some drugs, but the most common drug prescribed is non-steroidal anti-inflammatory drugs. They do have generally similar effect sizes or benefits to exercise, but we know that they have much greater risk of adverse events, and many people can't take them. And we know that they don't also give you the other benefits for all the health conditions that we talked about. There are opioids, but they're not effective, and they have a very high risk of serious adverse events, including death. There's corticosteroid injections, and these can give short-term pain relief, but generally we're talking just a couple of weeks. And also there's some evidence that perhaps repeated injections could speed up disease progression. And then there's joint replacement, and certainly joint replacement can be effective for the right patient, but 1 in 10 patients can have a serious adverse event. And also 20% of patients who have a knee replacement actually have a poor outcome. So it's not for everybody, and it's certainly not something to try unless you've tried all the other treatments, including exercise. And then lastly, as I said, people will weigh up and what their preferences are, what they value, and make a decision as to whether, based on everything I've said and what their preferences and values are, whether exercise is worth the effort. And so I think, I'm going to stop there now, but I do agree, in this case with ChatGPT, that exercise is absolutely worth the effort for osteoarthritis.
Wonderful. Thank you so much, Kim. Great foundational case. Marius, I might get you to share your screen now and begin laying the platform for your argument.
Well, thank you so much. Before I start, if I can get this to change. Before I begin, I have a quick confession to make. I have spent most of my career studying and promoting exercise, and today's argument is not my usual stance. I should say that this is an intellectual exercise looking at the other side. And you should think of this as an exercise that actually is worth the effort. So I come from Scandinavia up north, where we are, or used to be, Vikings, and we are so fierce that we have scared all the dangerous animals all the way down here to Australia. And as you can see, I'm on top of the world, and Kim sees things upside down because she's down here. And that's what I'm going to tell you today to show you. Now, Kim is Australian and you are simple people, so I will explain you, Kim, it is in a very simple way why exercise is not worth the effort. And I will start here. I cannot see everybody, but I'm assuming that you're nodding and agreeing with me when you tell me this is a flat line. And this is actually what you get out of exercising when we look at real world data. Not on trial data, but real world data. This is data from almost 25,000 NeoA patients from the GLAD registry, which is a registry of exercise interventions across the world. And this is pain measured on a 0 to 100 scale, with 100 being the worst possible pain and 0 being no pain over 12 months. And as you can see, this is what you get out of exercising. Now, this is not how it was presented, or typically is presented by the investigators behind these studies, who are firm believers and is standing in the corner with Kim Bennell. This is how they usually present it, and as you can see, they have fiddled a little with the y-axis. So now you don't see the 0 to 100, you only see 20 to 80%. But what you can see is the average improvement is about 13.1 millimeter on this 0 to 100 millimeter scale. Now, this is typically how you measure pain on a 0 to 100 scale. Now, if we look at this plot, and you have on the horizontal axis the pain before you start exercise, and on the vertical axis you have the change in pain after exercise. We can see you have this person, for instance, who starts with a pain of 62, and after exercise it's 44, so that would be a change of 18 millimeters downwards. Now we could have another patient over here who starts the pain with 21, And after exercise, it is increased to 59. So that's a change of plus 38. Now, if we do that for all these 25,000 people, it could look something like this. And if then we can add in the average improvement from the study, which was these 13.1 millimeter, and you can see that green line is laying right there. But then we can also talk about what is minimally clinically important improvement. And on this scale, this is supposed to be 18 millimeters. And then you can see that only 40% of the participants achieves a minimum clinically important improvement. That means that there is 4 out of 10 chances to get a minimally and clinically important improvement. Now that is worse than flipping a coin or winning on red on the roulette, or even there's a higher chance that rain will occur in Copenhagen tomorrow. That's the average of 50%. So is that really worth the effort to have that kind of odds against you? I don't think so. Now back to this, in all the research that Kim was referring to, we typically only include participants who has a minimum of 40 on the 0 to 100 scale. So now we can remove all these participants to the left, and then we have the average improvement would not be 13.1, but would move down to 18 millimeters. So that's actually just on top of the minimum clinically important difference. So now you can see that now it's 55 who achieves the minimum clinically important improvement. Now, what does that mean? Now, that does mean that all the research evidence that Kim is referring to is actually overestimating the effect out there in the real world. So should we believe in the studies? Well, we should at least be a little bit critical about it when we apply it to the real world. Now, if we go back to this observational study, there are several problems with that and other factors that could explain why we see this improvement. And one thing is what we call regression to the mean. And I will show you this. These are 3 curves of 3 different patients who over time have fluctuating pain intensities of their osteoarthritis joints. Now you can see that it varies, but the average across these patients are fairly constant. Now, the patients usually seek care or become participants in a clinical trial when they have a maximum pain intensity. So if we kind of switch these and overlay them together, you can see that this is where they start. And then the average will look like there is an improvement. So it is actually an illusion of effect due to what is called regression to the mean. So this has nothing to do with the exercise, but just the natural development of the natural course of history of the joint pain. Now, this has been quantified in a study done by Martin England, where he looked at a lot of people that was followed over many years. And when he kind of saw when they were eligible for participating in a trial, he kind of superimposed that on each other. And you can see that the regression to the mean explains about 0.8 to 1 on a 0 to 10 scale. So that's corresponding to 8 to 10 on a 0 to 100 pain scale. So if we go back to this and we can say, well, the average improvement was these 13.1, I will give it 14 points just to be nice. And then we can remove the 8 points from the regression to the mean, leaving back 6 points. Now, then there's another trial saying about the placebo effects in pain conditions on average is about 6.5 points in a 0 to 100 scale. So if we remove those again, then we are back to absolutely nothing. Or is there an effect? We don't really know. So I would say it is not really worth the effort considering all of this. And now I think it's back to Kim.
Wonderful. Thanks, Marius, the true Viking, demonstrating great prowess in delivering an argument. And Kim, over to you and your crocodile character for the rebuttal.
Thank you very much, David. Okay, you can see? Yes. Thanks very much for that. And that was very exciting and interesting to listen to, Marius. But I think that I can do better. you showed this graph, you talked about all these people showing what we call heterogeneity of effects. So as we know, we're all individuals. Not everybody responds the same way to exercise. Not everyone responds the same way to any treatment. So there is no treatment where every single patient is going to respond the same way. We're going to have it looking like this. So that means, yes, there are some people who may not get the benefits of exercise, but that doesn't mean we should throw away exercise for all the other people who do get some benefits. What in fact we should be trying to do instead is to identify responders and non-responders and work out what is it about those people who respond or didn't respond so that we can better either target the exercise or look at a different treatment that's going to be best for those people. And there is some work going on in this area looking at moderators, what we call, so baseline characteristics of patients, to see whether any of those can predict who is going to respond and who doesn't, although at the moment it's pretty hard to work out that at this case. But I still don't think that means we therefore just say, well, because it doesn't work in some people, let's throw away the whole treatment. And we've also been looking at, trying to understand what is the difference between responders and non-responders, and work led by Rana Hinman in our group did a qualitative study where she interviewed some people from a clinical trial that we did of exercise who we deemed to be responders, and that is that they had improved in their pain and function by the amount that Marius has stated, the 18 points. And we got another group of people who didn't respond in pain and function to the exercise program by that amount. And we asked them and interviewed them. And one of the factors that, well, some of the things that we found, some of the themes that we found that came out was that people discussed the beneficial effects of exercises on parameters other than pain and function. So they said, look, I didn't necessarily get the benefits there, but I felt that it improved other aspects like my knee strength or my confidence in my knee or the stiffness in my knee. And so we may not be measuring the right things in our clinical trial, and we have one measure or one or two primary outcomes, but people have different outcomes that mean the most to them. And there was comments that they felt that the methods used to measure exercise outcomes in the trials were inadequate and did not capture their main knee osteoarthritis problems. So maybe it's the fault of our research and our clinical trials and the outcomes that we're using. We're labelling people non-responders, whereas in actual fact, they are having benefits of exercise, just not the ones that we're measuring. And again, Marius has banged on a lot about MCIDs or minimal clinically important differences. But the problem is that there are problems with MCIDs, and that's because he picked out 18 points as the MCID, but that's not universal because these MCIDs can vary depending on the population that you've tested it in, the condition, the setting, the treatment. Might be different from resistance exercise versus joint replacement, for example. Also, you can use different methods to calculate these MCIDs, and they don't give you the same results if you use different methods. So in the literature, you'll find that there's a range of different MCIDs, and yet Marius was using those to say how many people have improved and to baffle us with all these figures. They also often poorly consider the patient perspective, and then they can be used in the wrong way. They can be applied at a group level when really we're talking about individuals. So Travis Haber in our centre has been doing some really nice work to do what's called a benefit-harm trade-off to calculate the smallest worthwhile effect that patients think is needed for exercise interventions. And so what this does, unlike the MCIDs, is that it takes into account what the patient thinks are the benefits, the harms, the costs, and the inconveniences. And so it takes into account all of these patient factors and their perspectives to calculate what they think is the smallest worthwhile effect of doing exercise. And he tested this in over 1,000 people with knee osteoarthritis, and he calculated the amount of pain reduction that would make strengthening exercise, he did it with strengthening exercise, but would make strengthening exercise worthwhile compared to no exercise. And he did it for looking at individual exercise, group exercise, or digital exercise. And this work isn't it's unpublished at the moment, but it's really interesting work. And what he found was that people with knee osteoarthritis thought that if they were doing individual or group exercise, they would need to get a 20% reduction in their knee pain intensity. Or if they were doing digitally delivered exercise, so online exercise, they would only need to have a 15% reduction in their pain to be considered worthwhile for them to exercise, taking into account the harms and the benefits and the costs, etc. And when you work that out and calculate it back to that 0 to 100 point scale that Marius has been going on about, it only comes to 8 points. Whereas Marius was saying you needed 18 points, whereas in actual fact, you only need 8 points if we assume the average baseline level of pain of 40, and that was for individual or group exercise. But for digitally delivered exercise, they only needed to improve by 6 points on that scale for patients to consider the exercise beneficial. So what that means then, we keep that in mind here. As I said, Marius has been going on about this MCID of 18 points, which is much larger. And so what he is doing is he's classifying that and saying that a lot of people who may have found that exercise to be beneficial, he's branding them as being non-responders. But if we use a different cutoff, we can see that more people would have been deemed to have benefited based on what they think. So here's his figure again. And if you see here, we've now shifted the line to what patients think is the smallest worthwhile effect. So there's many more people now that would be responders, if we call them, in terms of this. We also look at the data from our systematic review, our Cochrane review, and the average improvement with exercise compared with no exercise was 13 points. And that 13 points well exceeds that smallest worthwhile effect of 8 and 6 points. And again, if you compare it against placebo, because again, Marius was telling us that the placebo effect accounts for a lot of the effect, you can see that when we compare exercise to a placebo, the difference was less. It was only 8 points, 8.7 points, but that's still more than the smallest worthwhile effect that patients said would be worthwhile. So the smallest worthwhile effect for strength exercise that Travis worked out was about 6 to 8 points on that 0 to 100 point scale. And if you compare that, if you're doing a joint replacement, then patients felt that you needed to improve by 31 points, which is much, much larger. And that makes sense. If you're going to go to the effort of having a surgery, which is a big invasive operation, and it has the risk of, severe and major serious side effects, you want to have a big improvement. So that makes sense. He also used a lot of statistical jargon, trying to kind of confuse us with different, regression to the mean and so forth. So he talked about this regression to the mean, where what happens is people come in when their pain is worse, and then obviously they get better because they're having a flare, and then they get better. But when you're doing a randomized controlled trial, that design accounts for this regression to the mean because you've got two groups, and both groups are going to have regression to the mean. And so what you're measuring is the difference between the two groups over and above regression to the mean. So I don't think that's really a very good argument, Marius. I'm going to dismiss that one. He also talked a lot about the fact that, well, you do the exercise and it's the placebo effect of doing the exercise. The fact that you're doing the exercise and you're thinking you're getting better, or you're seeing a clinician, fine, because the patient doesn't care why they get better. Does it matter? The patient doesn't care. If they do the exercise and their pains got better, they don't care whether it's because the muscles have got stronger, their proprioception has improved, there's these placebo effects. They don't really care about that. They just want to get better. And in fact, there was this interesting study where they asked patients about placebos and should we use these clinically? And most patients found it acceptable for doctors to recommend placebo treatments. So again, patients just want to get better and they don't really care. And if that placebo treatment is beneficial, has no side effects or minimal side effects, doesn't cost much, fine. That doesn't really matter. So I think I asked ChatGPT to draw give me a diagram of me, kind of eating Marius, and it said we do not condone aggression and violence. So that's fair enough. So it gave us this little happy smiley face. So I'm very pleased that I could debate with Marius. And I do think that exercise is worth the effort. And I hope that I've convinced everybody, or at least convinced everyone to stick with their original idea that exercise is worth the effort. Thank you. And sorry, my summary here. This is why I think it is worth the effort. Beneficial for multiple health outcomes, including osteoarthritis, safe, doesn't have to cost any money, doesn't have to take very long, doesn't have to be intensive, and the type can be selected on whatever the patient prefers and whatever works best for them. Thank you.
Wonderful. Thanks, Kim. I'm really pleased that ChatGPT had to counsel you against violence. So, Marius, I'm going to hand the microphone back to you to respond in only the way a Viking would know how.
Well, thank you very much. Nice try, Kim. Kim is a professor and a very renowned researcher, but she referred to ChatGPT to get an answer in her first attempt to convince you that exercise is worth the effort. But she forgot a little thing on her first slide. She forgot that little disclaimer in the button saying ChatGPT can make mistakes. Please check important info. And I also asked ChatGPT just to see if I could get the same results. And I asked it why exercise is not worth the effort for osteoarthritis. And that gave me this. It says, why bother? You drag yourself to the gym, sweat through elastic bands and ergometers, and for what? Another day of knees that sounds like bubble wrap and ache like rusted hinges. Exercise is hailed as a miracle cure, yet it delivers the underwhelming price of slightly less knee pain if you do it forever, religiously, without missing a beat. If you miss a week and the knees laugh at you, the stiffness returns and you're back at square one. Honestly, if exercise were a pill, no one would buy it. The side effects are exhaustion, boredom, and lycra. And it goes on, and it actually agrees with Kim and with me. It says that exercise is not worth the effort because of the number needed to treat pain reduction is 4 to 5, which means that only 4 to 5 people will experience improvements. And that is from the Cochrane review that Kim so nicely presented to you before. It also actually quotes Kim here for saying that exercise for osteoarthritis is often touted as beneficial, but in reality, only about 40 to 50% of patients experience a minimal improvement. And that is something it found in one of Kim Bennell's studies. But Kim Bennell also talked a lot about this effect size, and she accused me of using scientific jargon. And I will say, well, right back at you, because you talk about an effect size. And what does an effect size actually look like? Now, this is how the data was before that I showed you earlier with all these individual changes. Now, if we split that into 2 groups as in a randomized controlled trial, it could look something like this. Now we have 2 groups, a orange and a blue one. And now we have an effect size of 0.1, which is a very small effect size. And you can see it's quite difficult to see the difference between the groups. Now, if we take a larger effect size, like 0.56, which is what Kim tells about, it's still quite difficult to see the separation between the groups. You might see that there's a slightly over representation of the yellow ones or the orange ones in the bottom, but it's still quite difficult to see the difference between the groups when you look at all these individual plots. So is this really worth the effort? I don't think so. Another way to look at the effect size, this is from one of my studies where I showed that for neuromuscular exercise versus no exercise for 12 weeks, 3 times per week, we could see a statistically significant, a difference of 6.8 points on a 0 to 100 scale. This is a Coos questionnaire, another type of measuring pain. But this comes out as an effect size of 0.71. Which is actually a very big effect size in exercise trials. But it corresponds to 6.8 changes in the 0 to 100 scale. So are the effect sizes actually an argument for the exercise is worth the effort? Well, I don't think it's worth the effort based on this. So you should not trust an effect size or trust a professor who argues for effect sizes as their main argument. So Kim also talked about if exercise can beat sham, placebo, or attention control, and she claims that it can. But actually, she's done 2 very nice studies herself that concludes that in the top one is physical therapy, which combined manual therapy and home exercises performed 4 times per week for 12 weeks against a sham ultrasound and some inert gel applied to the knees, or to the hips, sorry. And she concluded that among adults with painful hip osteoarthritis, physical therapy, exercise, did not result in a greater improvement compared to sham treatment, raising questions about its value for these patients. And she did the same for knee osteoarthritis and concluded that the physiotherapy program tested in this trial, and please note this was home exercises 3 times per day, so very much exercise giving there. But the program tested was no more effective than regular contact with a therapist at reducing pain and disability. And then she also mentioned the START randomized trial done by our colleague Stephen Messier in North Carolina in the US. And he compared high-intensity strength training versus low-intensity strength training. But he also had a healthy living control who was just meeting up regularly and chatted about healthy living, diet, and being physically active, going to bed at the right time of day, and so on. And these are the results. You can see over 18 months of intervention, all 3 groups improved to the same extent. So there was no difference between the exercises or the healthy living. So rather than going to the gym 2 times per week for 18 months, you could meet regularly and just chat about healthy living. And I myself did a study where we compared exercise and education with saline injections. So that's actually an open label placebo. And what we did was we compared 4 injections over 8 weeks of 5 milliliters of saline injections of saline versus exercise and education twice a week for 8 weeks. And what we found was that these 2 treatments were actually equally good. So it may be that Kim argues that exercise can beat placebo or attention control, but her studies and several other studies of high quality actually shows opposite. So exercise cannot beat sham, placebo, or attention control. So that means it's not worth the effort. But do we actually know, or do Kim actually know what we're talking about when we say exercise? Because exercise is many things. There's strength training, there are aerobic exercise, there are neuromuscular exercise, and so on and so on. And each of these are known to produce very specific effects in your body. So strength training would obviously give you greater muscle strength and make your muscles grow. The aerobic exercise will improve your cardiopulmonary fitness and capitalization of your muscles. And your neuromuscular exercise is supposed to improve your coordination and so on. So I think there should be a specific exercise type that is stronger associated with the pain relief than others. However, it does not really appear so. Here we have a nice meta-analysis. So that's a collection of all the trials out there. And they have categorized the different exercise interventions into aerobic exercise, strength exercise, performance exercise, and combined. And you can see the different exercise types actually yields the same effects. except for the combined exercise. That does not seem to be effective. So that really puzzles me. So if you do aerobic, it's good. If you do strength training, it's good. If you do some performance training, it's good. But if you combine them, it doesn't seem to work. But it gets weirder than that. Here's another study looking at it in another way, just another statistical way of crushing the data. So here you have the no intervention control as a reference, and then you can see that flexibility may give you some effect. Strengthening does give you an effect. Aerobic does not give you effect. But if you combine flexibility and strengthening, you get an effect. But if you combine flexibility and aerobic, there is no effect. And strengthening and aerobic together does not yield an effect as well. But if you combine everything, you get a good effect. So that makes it really difficult to interpret. Should we do specific exercise or combined exercise? It depends on how you look at the data. So we don't actually know what works. Now, we did a study where we looked at all the randomized controlled trials that was published back in 2019, and we found 100 studies that included 133 interventions. And then we looked at the descriptions of the exercise that was done in these studies and related them to what is called the tidier template. So that is a recommendation for scientists to report the interventions. And you should always report these 12 items. So that's a brief name and rationale, describe what materials you use for your exercise, the general procedures, who provided it, the mode of delivery, where you did it, when and how much, so that's the dose, how you tailored or progressed the exercise, if you modified it during the course, and how well it was delivered, and how, as you planned, and how well you actually delivered. And when we look at all of these studies, you can see that all of them, almost all of them, gave it a name, had a good rationale. But when we come to some of the more important things, like how to deliver it, only 3% of the studies reported that. And especially how much and the dose, only 16%. And very few studies reported very well, and no studies had complete reporting of this. So we actually don't know what's going on in the studies. So if we cannot learn anything from the studies, then how can we do it in the real world? So altogether, we don't know what to deliver, and we don't know how to deliver it. And if we, the experts, are clueless, then it's probably not worth the effort. So to summarize, well, real world data is not really impressive, and the trial results seems exaggerated, with only 40% chance of benefit out there. Wait and see is easier. It will get better as well, or healthy living as well. The effect sizes that she promotes are misleading and very difficult to understand. And exercise can't beat sham, placebo, and tension, not even in Kim's trials. And we don't know what we're talking about. So it's not worth the effort. You should just ask ChatGPT. So as you can see, I'm on top. Kim sees those things the wrong way. So thank you very much, and please vote for me.
Well done, Marius. All right, so now we've got a few minutes for question time. And what I'm going to do is I'm going to rapid fire ask both Marius and Kim just to comment on a few of these questions to facilitate that interaction. For the purposes of the discussion, now that I've shared that wonderful image, I can't see the chat, but all right, I'm going to stop sharing. Too fancy. All right. So again, quick responses to these questions, ideally. So is it reasonable to slot in a rest recovery day each week, Kim?
Yes, that's good practice for exercise. Let the muscles and things have a rest.
Marius, is there any evidence to suggest that exercise provides a different effect for milder OA versus advanced osteoarthritis?
No, exercise is equally ineffective for both mild and advanced.
Kim, back to you. Osteoarthritis is a broad church. Is exercise worth it for all osteoarthritis? Hip versus knee versus hand versus spine, a skinny person versus an overweight sedentary person?
Yeah, the evidence looking at like moderators, which is what you've suggested there for skinny versus someone with overweight or obesity, same effects. So that doesn't seem to influence the outcome. And benefits do seem to be seen at the different joints. Yes.
Is there any evidence of a difference between joints?
It may be less. I don't know a lot about the hand. I don't do the hand, but it seems to be less effective at the hand. You might know that, David. But it doesn't seem to be quite as good at the hand.
Agreed. Marius, what is placebo for exercise? And can you explain attention and how that works?
Well, we don't have a very good placebo, or we don't have any placebo for exercise, because if in order to make a placebo for exercise, you should do exercise that looks like exercise and feels like exercise, but is not exercise. So we have not invented that. I don't think we will ever solve that problem. And the other question was?
No, I think that's fine. It was just asking about attention control, which is, I guess, another.
Oh, attention control. Yeah. So attention control would be meeting up with a healthcare professional and doing something else than exercise, like talking about healthy living, or just having a similar amount of attention from a health professional as you would get if you went to a supervised exercise class, but not doing exercise.
Kim, is there any evidence to suggest that you can do too much exercise and cause yourself damage?
You can do too much exercise and cause increased pain, but that doesn't necessarily mean that you're causing damage to the joint. And in fact, what we know is that exercise doesn't, pain isn't associated with damage to the joint. So if you do a bit much and it's increased pain, then just, modify the exercise, have a bit of a rest day, change what you were doing, but no, it doesn't damage the joint.
Marius, physical activity question. How will swimming and bike riding benefit my knee osteoarthritis?
Well, as I tried to say, well, it doesn't really matter what kind of exercise that you do, it will yield some benefits. And swimming has the advantage of being unloading the knee joint. So if your knee joint or hip joint is not comfortable with doing exercise on land, then swimming or aquatic exercise will actually be a very good alternative. The same about cycling. It's gentle, and especially with cycling and swimming, you can get a high pulse, so you will get a lot of the other benefits that Kim talked about on your cardiovascular profiling, for instance. So that could be just as effective as any other program.
Kim, I'm just going to skip to some questions towards the end, just simply in the interest of time, because we want to skip to the vote in a second. Just coming to maybe Mel Holden's IPD. The next question is, are improvements on exercise dependent on age?
No, they're not. Age doesn't come up as a factor influencing whether you respond or not, or how much you benefit. No.
Marius, is there any evidence to suggest exercise slows the progression of the disease?
No, there's no evidence to suggest that. It can slow the progression of your symptoms and then delay the next step in your treatment, but it cannot alter the progression of the disease, at least as what we know now.
Kim, thank you for your argument. I think exercise is worthwhile for knee osteoarthritis, but how is this improving patients? Is it through confidence, self-efficacy, fear avoidance? What's the mechanism of effect?
That's a very good question, and we don't really know. And I agree that, we say we think it's because we're doing improving strength and so forth, but if there's not a relationship between, how much you do your dosage, then that would not seem to explain. So I think what does come up a lot of times is what you've said, improving people's self-efficacy, that is their confidence to be able to manage. So at this stage, we don't know, but they're very good. I think the main mechanisms that we see at the moment.
So Lon, I might get you to bring up the poll. Obviously, thank you so much to our wonderful combatants. And this is obviously a reflection of hopefully the debate, but please go ahead and vote. We are a democracy, or at least we're trying to represent ourselves as a democracy. And interested to see whether the vote was swayed from the beginning based upon the arguments that were provided. All right, still got a few more numbers to come in. It looks like that vote is slowing down. And for those people who did ask a question that I didn't get to, I do apologize for that. It looks like the computation of percentages here may be going a little bit awry. But for those of you that can see it, you can see that the final poll was 95% to 5%, whereas if I recall correctly, in the beginning, it was 99% to 1%. So I'll let you determine who was the ultimate winner in that. But ultimately, I guess in the first instance, wow. I'd like to thank Lon and the team for their involvement in helping to coordinate this wonderful exhibition of crocodiles versus Vikings. I'd particularly like to thank Kim and Marius for the wonderful way in which they've conveyed today's debate. And hopefully you've all found it interesting and engaging. And thank you very much for participating in this. And we'll look forward to seeing you for hopefully similar events in the not too distant future. Again, thank you so much for your wonderful contribution.
Thanks, everyone. Thanks,
Thank you.
Mark.